To understand the physical toll of pediatric hyperopia, imagine your visual system fighting a permanent blur. Your ciliary muscles continuously contract to pull the world into sharp relief, only for the image to slip away the moment your focus wavers. James is a 5-year-old patient who recently started school. An objective cycloplegic refraction reveals a measurement of plus 3.50 diopters in both eyes. Secondary visual function tests show an asymmetry. His right eye achieves a visual acuity of 6/9, but his left eye lags at 6/12. Furthermore, his stereopsis, or depth perception, is diminished, measuring at 100 seconds of arc. His grandfather brought him into the clinic because James has been rubbing his eyes since he began academic tasks in the classroom. A refractive error of plus 3.50 diopters in a 5-year-old is a moderate finding. It raises an immediate clinical question. Should this measurement be monitored, or does it require intervention? Junior practitioners often assume moderate pediatric refractive errors can simply be observed, expecting the child to naturally reach emmetropia as the eye develops. Relying entirely on raw Snellen acuity thresholds misses the complex neurodevelopmental processes occurring during early childhood. Safely managing pediatric refraction requires evaluating optical data through the filters of cognitive friction and amblyogenic risk. Pediatric optometry is a multifactorial neurodevelopmental equation. Success depends on addressing the visual pathway as a functional extension of the central nervous system. Contextualizing James's specific prescription requires looking at broader epidemiological data on childhood hyperopia. A pooled analysis by Zhang and colleagues examined cycloplegic refractions in over 15,000 children between the ages of 6 months and 6 years. James sits at plus 3.50. Because he falls just under this 4.0 threshold, a clinician might feel justified in taking an observation-only approach. However, the decision to observe fails to account for the impact of cognitive friction. Research by Rosner and Gruber shows that school-aged hyperopes manifest significant lags in visual perceptual skills compared to their emmetropic peers. A subsequent study by Roche-Levesque quantified this lag in preschoolers. They found that children with uncorrected emmetropia scored poorer on visual motor integration and WPPSI intelligence tests than the control group. Once the emmetropic group received corrective lenses, their cognitive scores caught up to the emmetropic control group at the 6-week review. This cognitive drag is driven by near-point visual stress. A study by Narayanamsamy simulated this stress in children using -2 diopter lenses to artificially induce hyperopia during academic tasks. When subjected to this simulated hyperopia, the children's performance plummeted. The time required to process psycholinguistic information exponentially escalated compared to their baseline. This performance drop became drastically worse following periods of sustained near work, exactly the kind of reading tasks James faces at school. Uncorrected hyperopia is an active, continuous drain on a child's processing power. The brain must allocate valuable cognitive resources toward basic optical clearing, creating a significant academic hurdle. We must also evaluate James's secondary visual function, his 6/9 right eye and his 6/12 left eye. To understand if this asymmetry is dangerous, we must cross-reference these raw scores against age-expected developmental norms. This box plot visualizes LEA acuity expected norms, outlining the acceptable distribution of monocular visual acuity for children between ages 3 and 6. Mapping James' 6/12 left eye onto the 5-year-old cohort shows his acuity falls below the median line for his age bracket. Falling below this age-appropriate median is a definitive clinical red flag. It forces us to evaluate the patient against the amblyogenic risk matrix, scanning for variables like low birth weight, strabismus, and family history. In James's case, the asymmetry highlights the most critical risk factor, anisometropia. The clinical literature is clear. Anisometropia greater than 1 diopter cannot be ignored. Leaving asymmetric visual inputs untreated triggers a rapid timeline for amblyopia, a condition where the brain ignores the blurry eye. Screening data shows that 14% of 1-year-olds with anisometropia develop amblyopia. That risk climbs to 40% in 2-year-olds and reaches 65% by age 3. As the child ages without intervention, the likelihood of amblyopia increases, and the physical depth and severity of the neural impairment compounds. Passively monitoring asymmetric inputs allows a temporary developmental lag to harden into a permanent neural deficit. This cognitive and epidemiological data informs the standardized rules used in daily clinical practice. The American Academy of Ophthalmology establishes these thresholds in their preferred practice patterns guidelines. The guidelines provide a structural logic for clinicians, categorizing prescribing thresholds based on the patient's age and specific condition. Locating the intersection for James, hyperopia without strabismus in a preschool-aged child, the data mandates intervention at the plus 3.50 diopter threshold. Because James has reached this precise measurement, clinical intervention is required. However, the guidelines dictate a nuanced approach. While myopia requires full correction, hyperopia without strabismus is often treated with a partial prescription, reduced by up to 50%. This partial correction removes the severe accommodative strain that causes cognitive friction, while leaving enough refractive error to stimulate natural eye growth. These matrices act as engineered safety nets. They balance the need for natural eye development against immediate neurodevelopmental hazards. We can now return to James's case file to execute a definitive treatment plan. A randomized clinical trial by Culp and colleagues examined the choice between immediate and delayed spectacle wear for moderate hyperopia. The trial found a moderate benefit to prescribing glasses versus observation in borderline cases. But the study identified a vital exception. The observation protocol must be discarded if visual acuity or stereopsis is reduced. We cross-reference this rule against our patient's diagnostics. James's asymmetric 6/12 left eye acuity and his diminished 100-second stereopsis directly trigger the mandate for immediate action. When combined with his chronic eye rubbing, the diagnostic ambiguity is removed. The evidence-based verdict is to prescribe corrective lenses. The pediatric clinician's core responsibility is dismantling the physiological barriers that impede a child's cognitive development and interaction with the world.